Good afternoon, ladies and gentlemen. Salam alaikum. It's my pleasure to be here. Thanks to give me the chance to present this case. Our case is a gentle female, 57, a little bit overweight, with no specific comorbidity except for hypertension. She was a heavy smoker with chronic anemia, with no previous admission for any cardiac problem. She presented in our ED with typical chest pain, shortness of breath, and easy fatigability. The ECG at the presentation was not showing any specific ST deviation, but the troponin was rising. So we decided to admit the patient. We performed fast echo, and the echo was not showing any specific wall motion abnormality and no valvular dysfunction. So we went directly through the angiography, and we did a lot of projection for this very nice case. She was a left dominant coronary artery with a tight lesion in the proximal LAD, as you can see in these many projections we did. And during the test, we saw that the blood pressure was damping, and we found even a tight lesion in the proximal left main. We should consider even that in the mid-LAD, there was a presence of positive remodeling that was involved in the proximal segment of diagonal branch. So after going through all the view, we decide to discuss with the patient about the strategy. So we have NSTEMI for a lady, young lady, with the left main disease, proximal LAD, tight lesion in dominant left circulation, which are the possible options we have. We can discuss with the surgeon for CAPS with double internal mammary arteries implantation, plus minus vein graft for the diagonal branch, or we can proceed for a complex left main stenting. We had a long discussion with this patient that she was really strongly refusing any kind of surgery and was asking only for percutaneous intervention. So after we explained to her all the risk and benefit related with the complex procedure, we decided to proceed with it. Everyone knows which is the empathic and emotional impact for CAPS for patients that are coming for the first time on our cath lab and our table, where we need to suggest to them to treat their problem with surgery. But we need even to consider that our brain, when this kind of situation are in our cath lab, is full of terror, is worry, full of fear, and thinking only about past strategies. And only a small part of our brain is focused on intelligent thoughts and evidence-based medicine. Anyway, we decided to proceed, as the patient was requesting, with the pre-dilatation of the proximal lesion and the LAD. We get a good flow, still the damping of the guiding catheter was affecting the procedure. Anyhow, we decided to proceed with the stenting on the proximal LAD with the 312 millimeter stent, and we used the balloon to predilate even the lesion in the left main. Everything was going smoothly, and the patient was fine. So we decided even to use the balloon to decide the exact length for the left main stenting, just to overlap a little bit with one strut the stent. This was because the mismatch of the left main and the LAD. Then we decided to put a stent in the left main with a small overlapping, and we decided to use the same semi-compliant balloon for the overlapping dilatation. But at the control, angiographic control, what we found was a huge extravasation of dye into a new chamber, as according with the Ellis classification, that is defined as type 3CS. What to do at this point? You know that when something happens in our cath lab, we have two pathways to follow. One is related with the patient's table, where you have time to think, you can ask for help, you can act, and decide your next step according with the present condition. But if the patient is not stable, you have no time to think, you have to act. You need to solve the issue. And especially for the main vessel perforation, if patient is stable, you have the time to cross another Y, to treat the distal perforation or proximal perforation, to use the balloon to tamponate the effusion. But if the patient is not stable, you need to really be more aggressive to solve the issue, because there is a pending life. So what we decided to do was just to check again, first of all, and we found that the flow in the distal LAD was not going well. So we decided to treat even the mid lesion with the direct stenting and preparing for the final treatment of the bifurcation of the proximal perforation. But the patient was really going into crash, so we decided to do the treatment with the pericardiocentesis, inserting the catheter ultrasound guided, and we proceeded with the graft stent in the proximal LAD. The problem was that we tried really to avoid the left main. We were hoping that the rupture was exactly on the ostium of the LAD. So we decided to avoid the left dominant circumference and stenting the LAD. But unfortunately, after the implantation of the graft master, we didn't seal it well. There was still a big extravasation at the ostium of the LAD, most probably, or at the ostium of the left 6. Till today, we didn't understand exactly where was this big extravasation. Anyway, after the insertion of the catheter for pericardiocentesis, the patient became stable. So we had a little bit more time to decide. We were looking to find exactly which was the position of the emergency of this big hole, but we didn't find. So we decided for the worst thing, that to implant to another graft master in the left main. As supposed to be, we excluded the left circ, and the patient developed a very severe mitral regurgitation, and her condition were deteriorating into shock. So an intra-aortic balloon pump was inserted and cardiac surgery was activated. She went directly to an operating theater, received 2 vein grafts on LAD and left circ. She recovered well from the ischemic condition. The mitral regurgitation disappeared totally. But during the rehabilitation, she developed some brain hemorrhagic spot, the biggest in the right occipital paramedian area, that according with the neurologist and neurosurgeon, should be treated by conservative management. The patient was discharged after 10 more days of rehabilitation with a good condition, without any neurological sequelae. So actually, the major complications of percutaneous coronary intervention are rare, but can be catastrophic if not successfully managed. In the balloon era, complications were really rare, but now in high volume center PCI operators that are performing novel interventional techniques, including hemodynamic support device assisted PCI and revascularization of CTO lesion, have resulted in higher success rate for complex PCI, but also higher complication rate. This is what we are leaving in the cath lab after solving this kind of problem. In take-home message, in my opinion, PCI is a common invasive procedure with a relatively low complication rate. However, when complications do occur, operators may be unprepared to manage them. The presence of doubts about complication management could contribute to the under-treatment of patients with high complexity, high-risk coronary disease. Complication management requires preparation, early recognition, and broad differential diagnosis, knowledge of effective techniques, team-based communication strategies, and multidisciplinary collaboration. A systematic approach for complication will improve procedural outcomes and provide confidence for operators who plan to perform complex PCI. It's always crucial for the patient's safety to remember what the ancient Latin said, primum non nocere. First, do not harm. Thank you.